Hello, my name's Ian McCall, and this is a video on the images used in Module 7a, superficial fungal infections. I think there's a couple of facts here at the beginning that we need to get across straight away. I've said as far as you're concerned, there's going to be three types of superficial fungal infections, either dermatophyte fungal infections or candidiasis and tinea versicolor. The latter two are yeasts. Now, fungi eat keratin, and so the major structures that they're going to affect are going to be the stratum corneum, these dead keratin cells on the surface of the skin, and structures such as nails and hair, because these are just solid keratin. So, as all of these are superficial structures, most fungal infections are superficial. They don't go deep through the basement membrane. Now, as I've said there's a different group of fungal infections called the deep fungal infections, and they exist and reproduce in the dermis or deeper. And we'll deal with them in the next video and in the next part of this module. Now, this little bit here, another important concept is the host's immune response to a fungus. Fungi can be anthropophilic, meaning they come from another human being, geophilic, meaning they come from the soil, and zoophilic, meaning they come from a different animal. And it's the zoophilic fungi that get the major immune response because they're so different. A fungus from another human doesn't develop the same florid immune reaction than one does if it's from an animal. So, with those little facts, let's have a look at the images. You've got to get your eye in with fungal infections. They're often quite subtle. And these three here are dermatophyte infections on the surface of the skin. Look at the edge. The edge of a dermatophyte infection should be scaly. If you look at this here, you can see the scale. Look at that fine scale at the edges here, all the way around. If you're going to scrape this for fungal hyphae, you should be scraping the edges. So you scrape it for fungal hyphae in culture. Hyphae are the growing structures of a dermatophyte fungus, and they're visible under KOH microscopy when they have a look at the fungal scrapings. You can see this is all involved in the dorsum of the foot here and this spreading edge. It's a classic fungal infection, a dermatophyte infection. Here's another one. It's on the back. That's the edge there. There's another bit extending down here, and this was a very extensive one on a man's back, and it was extensive because he had had topical steroids applied to it, and that was suppressing the immune reaction, allowing the fungus to grow. If you look carefully, you can probably see little pustules there. In point of fact, it's more visible. This was a close-up from the edge, and this occurred when the steroids were withdrawn, and his immune system suddenly recognized there was a fungus there and mounted an immune reaction to it. And these pustules are just a reflection of the number of neutrophils that were mounted to try and attack this fungus when the immune system sort of recognized it. So, as I say, they arose when the topical steroids were stopped. Now, a few other unusual ones. This is an old image that was given to me, and it says hand and foot involvement of trichophyton rubrum. This is quite florid for Trichophyton rubrum. Trichophyton rubrum is a anthropophilic fungus, and usually you don't get as much reaction as that. But you can involvement of the palm of one hand and the sole of one foot. Or you can have the soles of both feet in one palm and the other palm quite normal. Always have a good look at the nails as well and see if there's other problems. He's obviously a smoker from these brown fingers, and it looks as if he's even lost a bit of a digit here. So he might have been diabetic as well. Here's another rash that isn't really, well, it's got a name that sounds like a fungus, and it's called trichomycosis axillaris. And it's these little yellow concretions, these sort of yellowish things here, here, and here, that are attached to the hairs, matting these hairs in the axillae together. But this isn't a fungus, it's actually a corynebacterium infection. And so it smells. But the best way to treat it is to shave the flaming arms for starters, and then use a bit of the armpits, and then use a bit of the clindamycin lotion or some oral erythromycin, because that'll knock off the corynebacterium. It's usually a hygiene thing in excess sweating. And here's another little thing where corynebacteria cause problems. Sweaty feet. But look at these little holes here, little keratin holes in that area, which is macerated. And this is due to corynebacteria eating away the keratin here. So again, this will respond to some oral erythromycin, oral clindamycin, or clindamycin lotion. So remember, pitted keratolysis. It's a bacterial infection, it's not a fungus. Now, here we get on to intertrigos, or at least intertriginous infections. Note the difference between these two. Under the breast, notice the edge in this one, notice the satellite pustules in this one. This is candida, intertrigo with secondary candida. Maceration from heat and sweating, but these little pustules all represent secondary candida. Use some hydrozole cream. Try and keep the breast separate with a little bit of cotton, or cotton handkerchief or something. Lose a bit of weight. Check that they're not diabetic as well. This, though, is different. Look at the advancing edge of this. There's no little pustules out here. There may be some pustules just in the edge itself, but there are no satellite pustules. So this isn't candida, and it's more than just an intertrigo. Remember, an intertrigo, where the two surfaces come together, it tends to have a very smooth, continuous edge, where the two occlusive surfaces meet. Whereas if you've got a dermatophyte like this, look how irregular that edge is, where the dermatophyte's growing out at different rates. Same here. It's not just confined to the actual occluded areas here. So you'd scrape this. This hydrozole would help it because hydrozole has clotrimazole, but you'd be better with something like Lamisol, which is a fungicidal drug, topically, and it'll knock that off better. And here's another one. Inner groin. Look at that color. Very definite edge here. But this you might think is a tinea, but it isn't. This is erythrasma. And again, it's another corynebacterial infection. And again, it responds to erythromycin or clindamycin topically. If you shine a blue Woods light in it, it fluoresces coral pink like this. So that's a classic sign of erythrasma. So corynebacteria can give rise to erythrasma, give rise to pitted keratolysis, and give rise to trichomycosis axillaris. What about this one? This is tinea incognito. This is your spreading edge here, all the way up here, and it's down here above and into the eyelid, and it's extending all the way down here. And the redness is reduced because topical steroids have been applied, and that encourages the fungus to spread because of a reduced host immune response. So these can be difficult to pick up. That's why you've always got to know what someone applies to their skin beforehand to see whether the rash may be modified. Again, even with this one, look at this. There's the edge here. This is all fungus down here. Look how the texture's different from here. There it's also involving all this up here, here, and it's going all the way across the back here. So this is all a dermatophyte infection. It'll be an anthropophilic fungus because there's hardly any sort of immune reaction to it, so it's probably Trichophyton rubrum or one of the other zoophilic fungi. And this is another one. There's the person's two palms. This one's all scaly accentuation of the dermographic ridge markings on the palm. This one has Trichophyton rubrum on it. This one's clear. Look how little of an immune reaction there is here. It's all just scaly. Anything that's red and scaly, scrape it. Now, we said before that dermatophyte fungi live in keratin, and hair solid keratin, so you're going to get tinea infections of the scalp. Look at this one here. The hair, first of all, it's a red scaly disorder, so it's PM's pet. But the hairs have been broken off at different levels because the hair shaft is involved by the fungus that weakens it, and so the hair breaks. So you'll find hair here at different levels. But this is tinea capitis. You should do scrapings of this and send some hairs. Just pluck some hairs and send them down in the container as well when you're looking to see which fungus is involved. That's not very inflammatory, so it's unlikely to be an animal fungus. Whereas, and this, what was this one? Yeah, this is a very much more extensive tinea infection in the scalp. You can see little areas of hair loss here, you've got some scabs. It's red and scaly. Again, you'd need to scrape it, but you seldom see tinea capitis as extensive as that. You know, hair's been lost here and then it's starting to regrow a bit. And here is a carrion. This is an animal fungus, massive immune reaction, pus, discharge, and this inflamed tender boggy mass is due to that good inflammatory reaction to an animal fungus. You've got to treat this with oral steroids early on to settle the immune reaction, to settle the edema that's there, or else it really does leave a big bald patch afterwards that's permanently scarred, and it, you know, the hair just never grows back there again. So oral steroids and systemic antifungals, and you need to treat a carrion. So what other things have we got here? All right, here we come to another thing that's called tinea versicolor, or pityriasis versicolor, but it's not a dermatophyte. It's a yeast, Malassezia furfura, Pityrosporum ovale. In a white person, it presents as these pink areas, and they're not overtly scaly, but if you take your finger to them and just scratch them, you'll find a very fine pityriasis or bran-like scale, different type of scale to the scale that you get in psoriasis. And this was just a close-up of it here. Now, in contradistinction, if you get someone who gets tanned, then what happens is that the normal skin tans, but the areas that are infected by this yeast doesn't, and they stay white. And a lot of surfers will get this white spot disease. I mean, this is a really extensive one. Look at all of this. This is all this yeast fungus on the surface of the skin. A case like this would need some Nizoral orally, 200 milligrams orally for 10 days, and then 200 milligrams weekly for 10 weeks. They can also use a bit of Selsun shampoo overnight, washed off in the morning, but it wouldn't do much for this. And you can use topical antifungals like Lamisil or clotrimazole, but again, you really need the systemic antifungals to settle this down. But note the differences between white on tan skin and pink to red on white skin. What are we doing? A little bit more on Candida by the looks of it. Now again, these are these satellite pustules coming out from, you know, most people look at a groin and say, you got tinea infection. This is intertrigo again with satellite candidiasis, so it's hydrozole cream they need. Remember, if you had given that patient griseofulvin and it's a yeast infection, griseofulvin won't work with yeast infections. Lamisil orally will, but griseofulvin won't. Griseofulvin's a fungostatic drug, and it's only of value for dermatophyte infections. There's a good going plaque-like tinea on the tongue, you know, extensive oral thrush of candidiasis. You can, in fact, wipe that away, but that is a really extensive one. And this is Candida in the glans penis. Again, you've got this white adherent surface that can be wiped away. You might look at that and think it's maybe lichen planus. It isn't. That'll all wipe away. Lichen planus wouldn't. Always I've said there, you know, check them for diabetes. Any female that presents with really extensive candida around the perivulval area, or a male around the genitals like this, or even this one back here, I'd still check them for diabetes. There are a couple of rare types of candida as well, and this is chronic mucocutaneous candidiasis. This is a genetic type of candidiasis where this wee girl was sensitive, or sorry, she had no immune response to Candida. Her immune system was perfectly okay for everything else, but she couldn't hit Candida at all. So she presented with this chronic candidiasis in the inside of the mouth and the angular cheilitis here. She also had gross involvement of her scalp. I think you'll see her picture later. And they get gross involvement of the nails. You know, usually you only see this in immunosuppressed patients where Candida invades the nails like this. Look how grossly affected these nails were. When it was all cultured, it was all Candida that was doing this. But this is called chronic mucocutaneous candidiasis. And the other little form of Candida is here, web-space candidiasis. Now, I've said here always check for a dermatophyte infection. And sometimes even erythrasma can present here. But I mean, that's white and eroded. Erythrasma usually doesn't present like that. So that's a Candida web-space infection. Chronic mucocutaneous candidiasis for these. Now, another little fungus that can give problems is a yeast called pityrosporin, and this can occur in pityrosporin folliculitis. I've said that it's common in diabetics, people who are immunosuppressed or on steroids, and much more commonly in the tropics. Looks a little bit like Grover's disease here. But it's not scaly on the surface in the same way as Grover's is, and there's sometimes little pustules, and it's itchy as well. Mind you, Grover's is itchy too. But this is pityrosporin folliculitis. Here's another example of it here. I find it a difficult diagnosis at times. I don't make it. I don't make it readily. I mean, looking at that, there does appear to be a bit of scale on the surface, and because of the site, you just might go and diagnose it as Grover's and give them a strong topical steroid, which wouldn't be the way to do it. Some scrapings if it's red and scaly, first of all, and they do have to use a special media to grow pityrosporin. This will respond to Nizoral orally or to Lamisil topically. I prefer the Nizoral orally to treat it just 200 milligrams daily for 10 days. And we end up with these three. I did have these important points here, and I think it's important to note them, that the superficial dermatophyte infections are easy to miss, and know the various presentations of pit versicolor and how to manage a carrion in the scalp. And I've just ended up with these three images here. This was an obese diabetic. This was the spreading edge here. Coming up from her feet, her nails were involved as well. She's got pustules as well, and sometimes you will get a reasonable pustular eruption in a dermatophyte infection. This you may see. Well, we occasionally see it here in the Gold Coast. It's more common up in the tropics. A browny black mark that is on the palm of the hands, much more common in the soles of the feet. And if the thing is, you might look at it and think that it's some sort of melanoma, but if you look at it first of all with a dermatoscope, usually gives what's called a parallel furrow pattern. But even then, you might still think it's melanocytic, but it isn't. It's a black yeast that's in the keratin on the surface. And you can scrape it off with a blade, but it'll also respond to a bit of clotrimazole or Lamisil cream. And lastly, know how to take nail scrapings. Get this one's grossly thickened, but you really got to get into the material at the end here, or if you can get your blade just underneath the nail here and scrape the undersurface, then that material is very handy for, well, it's actually the best sort of material for trying to show fungal hyphae and grow a dermatophyte. And then you can order terbinafine or Lamisil cream, Lamisil tablets orally. It's usually 250 milligrams daily for generally about 3 months, 12 weeks of therapy. Comes in 42 in a packet. You have to wait till you get your microscopy or your culture back as positive, and then order it as an authority from the health department. So that's a quick overview of the images in these superficial fungal infections. Dermatophytes or yeasts. Remember Candida, remember pityrosporin. Note the difference between the two. Remember As I say, Corynebacteria look like fungi but aren't fungi. They're a bacterium. Okay, those are the superficial fungal infections. The next video will be with the deep fungal infections. Thank you very much.